Welcome to the work of arthrotomy in this MACI Work of Art series. And if you have any questions that come up during a presentation, there is a chat, which I'm going to try to monitor. And then, of course, there are some dedicated times as well where we'll have some question and answer sessions. Please remember, keep your audio on mute unless you are speaking. And then you can type questions into the Q&A box at the bottom of the Zoom screen. I'd like to welcome the three others with me. Dr. Kreitler from Texas Tech Physicians in Lubbock, Texas. Dr. Meininger from Steamboat Orthopedic and Spine Institute in Steamboat Springs, Colorado. And Dr. Lupowitz from Longevity Physical Therapy and Performance in Hampstead, New York. And I look forward to learning a lot from those three today and from their extensive experience. Here's our disclosures. We are consultants of Vericel Corporation, and information contained does not constitute medical advice. These are some mandatory slides about the indications for MACI. And just as a reminder, it is an autologous cellularized scaffold product indicated for the repair of single or multiple symptomatic full thickness cartilage defects of the knee. Some contraindications are listed there, and some warnings and precautions. Definitely contraindicated patients with a known history of hypersensitivity to gentamicin and products of porcine or bovine origin. Specific populations, use of MACI in pediatric patients or in patients over 65 years of age has not been established. I'd like to start with just an overview of MACI. In 1995, it started with Carticel, which were cells in suspension. I don't know how many of the panelists and attendees have used Carticel, but it involved sewing circumferentially all the way around the cartilage defect, sewing a collagen cover, like securing a tarp across a bathtub, and then you would inject Carticel underneath. And so a typical defect may have 20 to 25 sutures with 6-0 suture. So as you can imagine, you need quite good exposure for that. And the very early end of that, we were using the patient's own periosteum, which was tough to work with. It would like to roll up and was a bit uneven. And then in 2016, we've had MACI, cells on a collagen membrane. And as many of you know, suturing is not mandatory. Some cartilage defects can be treated with just fibrin sealant alone, glue under it and glue around it. Although often I'll use a suture or two or three, just to secure it in various areas. But that was a huge upgrade for me because, as you can imagine, if I was treating 50 or so cartilage defects a year and I was saving 30 minutes of time for each one, that was 25 hours of extra life every year, just a full day of extra life per year from 2016 on. So I was pretty excited about that. And along with that, I wouldn't need as much exposure because if I was sewing circumferentially, you really need pretty good access to pass a needle around some of those angles. But if I'm just passing one or two sutures, I don't need as much exposure. In 2019, we started using some more advanced instrumentation, like some of the cookie cutter techniques. And then now we have MACI Arthro as an additional delivery option for patients with cartilage defects less than 4 centimeters squared. MACI's simplified ACI can be implanted via standard arthrotomy or arthroscopically. I really like the versatility and flexibility. If a cartilage defect is a perfect circle, well, then you have various options. But a lot of times the cartilage defect is in a bit of an unusual shape. It's longer than it is wide. And I like MACI, especially for those instances. Some of them, the trochlea can have unusual shapes. I mean, MACI has entire flexibility. I've had cartilage defects in the shape of a man wearing a jetpack, and you can just cut it out right in the shape and just glue it in place. It was dolphin shaped. It doesn't need to be a perfect circle. I really like that flexibility. And then I like the results. I like the gold standard aspect, one of the most studied treatments in orthopedics. And when you look at it by case, it's definitely one of the top studied treatments with about 50 publications on its clinical results. This Venn diagram is nice. It shows in the center that MACI is indicated for adults with symptomatic full thickness cartilage defects. And then on the left side are more of the arthrotomies, bigger defects. And on the right side for MACI arthro, defect size less than 4 centimeters squared. And there might be some cases, just like for those of you that are shoulder surgeons, like I can imagine treating a slap tear open, but arthroscopically it's a piece of cake. Same thing with the knee. I mean, I can imagine what it was like to treat a plateau fracture open, taking down the collateral ligaments and then repairing them at the end. But arthroscopically, treating a plateau fracture, I don't want to say it's a piece of cake because there still are some challenges with it, but it certainly is a lot easier than open treatment of a plateau. MACI of the lateral plateau comes up quite a bit. This is very important. If you spend any time with me in the office, you'd see probably about a third of my cartilage repair patients are patellar dislocators. They have MPFL instability. About a third of them are ACL deficient, and they have ACL deficiency. And then about of the third of them that aren't in any of those groups, about half of them are meniscal deficient. And then I always check alignment from the center of the hip to center of the knee, center of the ankle. We have those EOS treatments at CHOP and at one of our adult hospitals that I like to use because it's 1/6 of the radiation. But this is very important to think about. The other thing actually on this slide is probably the most frequent question that I get is, what order do you do these things in? So I'm going to go over the two biggest scenarios. For me in my practice, one is the cartilage repair in the patellofemoral compartment, but they also require an MPFL reconstruction and tibial tubercle osteotomy. The first thing I do is one longitudinal midline incision. And I do everything through that. I appreciate there's other ways to do it. You can do it through a 6-pack of smaller incisions maybe. But this is, after all, the MACI arthrotomy course here. So I do it through one big midline incision. The first thing I do then is I pick the MPFL attachment site on the femur. And I do that with Schottle's point. I should note that if I have not done arthroscopy of the knee before, for example, if they were referred in by someone else that did the biopsy, I do repeat the arthrotomy. I look for new loose pieces. I trust my referral sources, but at the same time, I like to, trust but verify. And in some of the referral sources, I might not know yet. So in which case I usually start with an arthroscopy. But I do it through the big midline incision. Then I choose the attachment site on the femur, Schottle's point. Then I harvest quadriceps tendon. That's my preference with a turn down technique where I fold it down, or as Dr. Ganley says, turn down for what? And and I have that prepared. I don't pass the suture through the tendon yet because I don't like the suture just lying on the skin and culturing bacteria in its braids. But I could, but I don't. I harvest the quadriceps tendon. And then the next step I do is the lateral release or lengthening into the tibial tubercle osteotomy. And then for these cartilage repair cases, I do more than just crack the tibial tubercle osteotomy distally. I actually, in most of these, will completely free it up. And then it's like lifting the hood up on a car. Then it gives good access to the patellofemoral compartment. And I'll do the MACI, which people will often comment, geez, that was the easiest part of this surgery. And then secure down the tibial tubercle. I usually shift it over about 8 millimeters as a rule of thumb. And then I'll do the MPFL reconstruction as the last step. And the other scenario is the meniscal transplant, ACL revision, ACI. And people often ask, well, what order do I do stuff in? Same thing, one big incision down the midline. I do, the first thing I do is I will harvest the IT band. I leave it attached to Gertie's tubercle for the extra-articular tenodesis, the LET or lateral extra-articular tenodesis. I harvest that first because I find that if you do the arthroscopy first, it's very hard to vacuum all the water out, and it's like operating under a waterfall and everything gets descended over there. So I do that first. Then I'll do the meniscal transplant and then the ACL reconstruction. And then I'll do the arthrotomy. And I almost always do a medial parapatellar arthrotomy. For the lateral defects, I used to alternate every other one to see which one I liked better. Well, I definitely like the medial arthrotomy better, even for the lateral defects. It just brings everything out of the way better. And then, again, the MACI is the easiest part of the case, especially compared to a meniscal transplant. And then I'll repair the arthrotomy and secure the lateral extra-articular tenodesis at the very end. And then here is the MACI implant overview. The first step is a defect assessment and cartilage biopsy. I really like this step. If someone calls me from another institution, they say, do you want me to do the scope, take the biopsy, and then send them? Or do you want to do your own biopsy? I mean, I like to do my own biopsy, but it's more for the defect assessment and the knee assessment. I tend to be a tough grader. Sometimes people are like, well, the ACL is intact. Yeah, it was intact as a CCL, a central cruciate ligament, but I want to know, is it intact as an ACL, controlling rotational stability? And so I like to look at the knee. I like to grade the menisci myself, look at the cartilage defect, make my own measurements. I cut a little plastic ruler, I put it in. I actually enjoy the defect assessment. That's when I make the plan. And if you tell someone the plan after the biopsy, but before MACI implantation, well, that's an explanation of what you're going to do. If you tell them the plan after the MACI implantation, well, then sometimes it can be an excuse, I like to tell them everything to expect in terms of the success rate that I anticipate and what's involved after the cartilage biopsy. I make the plan during that arthroscopy. And then where do I take the biopsy? My preference has changed a little over time. I used to prefer the far lateral aspect of the trochlea, and now I prefer the far medial aspect of the trochlea. I've avoided the intercondylar notch a bit because I've seen a subset of them where I felt like some have developed osteophytes there as a result, and some have looked to have damaged the patella a little bit in deep flexion. So I like that far medial. I think it's easy. I use a curved gouge, and I take, about the size of a Tic Tac piece there, about 7,500 milligrams. And then the MACI implantation, you'll hear more about that today. It can be done through an arthrotomy or a mini arthrotomy or arthroscopically. I like to use just a little bit of the time at the end to just ask each of the panelists a question about their pre-surgery discussion with the patient and what they like to talk about between steps 1 and 3, between the biopsy and the implantation, maybe we'll start with Dr. Kreitler, what he likes to tell the patients.
So if I have a patient who, based on their imaging and their clinical exam, I believe that MACI will be a good treatment for them, then this is what I tell them. I say, the surgery that I would recommend for you is actually 2 surgeries, but the first surgery is very minimal. Simple knee arthroscopy with 2 very small incisions. I go into your knee, assess the situation, I measure your cartilage defect, and then I take a very small biopsy of your normal cartilage. That biopsy gets sent to a lab in Boston. They grow out your cartilage cells in the lab, and then they implant your cartilage cells into a collagen graft. Then about 6 to 8 weeks after the first surgery, we do the real surgery. The real surgery involves opening up your knee, most often, taking a look at that cartilage defect, and then cutting out that collagen scaffold with your own cartilage cells in it and gluing it into your defect just like a puzzle piece. I think when I explain it like that, it reassures patients in 2 different ways. Number one, you always hear, oh, well, patients don't want to have 2 surgeries. But when I say the first surgery is very minimal, I've never had a patient say, oh, well, I don't want 2 surgeries. I think that first surgery, I really don't have any restrictions afterwards. I have them use crutches for a day or 2, but there's no brace. They can do whatever they want in between. So that reassures them. The other thing that I think reassures them is that instead of just jumping into a major surgery, by first doing a minor surgery and assessing the situation and confirming that MACI is indeed the correct treatment for this patient, I think that also reassures the patient and lets them know, okay, the surgeon's not just jumping into something right away. He's really going to make sure this is the right thing for me. And so I think that also reassures these patients.
Yeah, now I'm in Philadelphia, where you probably saw the recent study. We actually now have more lawyers than we have people. So I'm always really cautious. I like to do an arthroscopy before any big surgery. I mean, I do before
Yeah.
a fresh osteochondral allograft, for example, or
Yeah.
anything that is like that. So it's no difference for me. So I appreciate hearing that. How about Dr. Meininger? Do you have anything to add? Is your approach any different?
No, I echo what you guys say. Dr. Kreitler, I like your approach to sell it as a minimally invasive approach. Get a pre-op plan through the initial scope, get a dynamic assessment of ligamentous integrity, especially like you say, Dr. Carey, my patellofemoral cohort is probably a third or greater of my MACI population. And so it's that patellofemoral stability, their alignment and stuff that's helpful to analyze. I think patients really resonate when you bring up that MACI is autologous and you explain it to them. It's their own cells, it's their own DNA. Of course, there's single stages. You can use cadaver bone, and there's a role for osteochondral allograft, of course. I tend to think the 3-dimensional morphology of the V-shaped trochlea and the dynamics of the patella resonate well for MACI and pasting that surface. So I recommend it in those cases, and I tell them that I think this is your best option, and we can clone your own cells, we can paste them in place, and it's like planting grass seed, if you will, that we can watch new cartilage grow in place of where this unfortunate fracture may have occurred. And if I take one step back quickly, Dr. Carey,
Of course.
I love your approach with the arthrotomy and the single incision. When I have those complex multi-stage procedures, I often try to do a lot of my drilling arthroscopic first. So I'll get my posterior meniscal tunnel in place, get my meniscal draw suture in place, get my femoral ACL tunnel there, and then I might accomplish a lot of the remainder of the surgery in open technique, even docking my graft. And then the last step might be securing the tibia on my ACL. But before that is probably finishing my MACI, making sure my range of motion is intact, then locking my tibial fixation of the ACL and closing from there. But yeah, I love the way you talk about it because that rings a bell in my practice.
Well, thank you. And Dr. Lupowitz, what do you tell, like if you're working with an athlete or or a patient before surgery? What do you like to tell them?
Yeah, I think the biggest component is the adherence component. Quite often after that first stage procedure, they're going to feel pretty good, and they're going to potentially start to question, what is the need for that follow-up procedure? But, having an open line of communication with the surgeon, the patient, and really creating that team approach, I think is the biggest point to drive home for them. Ensuring that they don't do too much too soon after that first procedure, because we know that they can potentially extend that defect, and we don't want to warrant anything moving forward in that second process. But you also want to kind of let them have a little bit of free rein, in the sense that we kind of know that it's, up to 6 months to roughly usually a year for that second period to return, at least full go. So you want to kind of at least just set the stage for them. What are the expectations? What do they potentially need at home? How can the family be involved? What devices are helpful early on? What should they expect long term? But also in that early phase, I think biggest thing is not do too much too soon.
Thank you. Well, we're pretty much on time. While we're passing, I've had a few patients ask about what's the long-term benefit of filling a pothole on a good road, doing MACI, especially when they're doing well, like Dr. Lupowitz brought up, after, removing loose pieces. I usually review with them the Rochester Epidemiology Project work on osteoarthritis dissecans, where when they left the pothole empty, about 30% needed their knee replaced at 30 years. If they did anything to fill it, it went down to 10%. And then we know from some of Dr. Peterson's work in Sweden that if you do something gold standard, like autologous chondrocyte implantation, we can bring that down to like 3 to 5%, at least at 20 years, we have follow-up. So I think there is some long-term benefit to preserving the knee. But I see that we've transitioned to control, and we'll move on to Dr. Meininger.
Thanks, Dr. Carey. Appreciate it. I'm excited to get to present and talk to you more. We had opportunity at the International Cartilage Restoration Society, the ICRS 2025 meeting, to share our abstract. In our practice, we did a retrospective review of all MACI recipients from 2017 to 2025. We had a cohort of about 35 patients over that duration. That gave us 8 years of consecutive results, and it was exciting to go back and look at them. We were able to use a remote patient-reported outcomes database through Vanderbilt University and the REDCap system, which physicians are not aware is an excellent resource and tool, and it might be an opportunity to collect some outcomes and patient-reported scoring in your own practice. We sent a survey to all of our MACI recipients. We got 25 of them that completed it with an average of almost 4 years of follow-up. That included 28 knees and 25 patients, and 15 of them were patellofemoral. Both trochlear and patellar were grouped together, and 11 of them were femorotibial lesions, mostly condylar, obviously. We often associated these with realignment procedures, as shown, and a combination of coronal realignment with distal femoral osteotomy, opening wedge high tibial osteotomy, and anterior medialization, Fulkerson-type tibial tubercle osteotomy. If we go to the next one, Matt. We were able to look at return to sports and categorize them as low, medium, high intensity, as well as collect a series of PROs. There were Tegner scores, Mark's activity scores, IKDC scores, and it helped us to catalog and get results. I had patients that progressed into Division III and collegiate football and collegiate basketball, high demand activities like downhill skiing, competitive skiing, snowboarding, backcountry skiing, of course, up here, and then mountain recreation activities, if it's rock climbing, motorcycling, mountain biking, and a competitive gymnast as well. We were excited to see that our results matched that in the literature, and we were able to get about 84% of our group that returned to a high level of sports or even the level of activity they desired. That's exciting to see, because cartilage restoration is sometimes intimidating, especially in the community practice, if you feel you may not have academic resources or a large tertiary center. But with, I think, a interest in cartilage repair, a technical skill and training, I think MACI is appropriate for many different surgeons. If you're interested and seek out that experience, you can get successful results if you apply it correctly with the principles of cartilage repair in place. Next slide, please, Matt. Our satisfaction scores were high, and our return to sports were on time at 9 to 12 months. You can see our IKDC scores were 84, and that exceeded some of the published literature from some of the big institutions of about 79%. We did have 3 patients that required return to surgery for different problems. One was a symptomatic HTO hardware. This picture on the left is the graft integrity at that stage, which was about 27 months post-op. The first generation HTO plate and screws was relatively bulky, symptomatic, but the scope showed that medial femoral condylar defect had healed and integrated well. We had another case of a graft hypertrophy, but out of 35, only 1 case of having to go back for a chondroplasty. I think that resonates too, where MACI has reduced impact or early range of motion, helped to prevent that previously known ACI complication of over thickening the graft or graft hypertrophy as a potential MACI complication. And lastly, I had 1 patellar defect with graft failure, and it did require revision surgery with osteochondral allograft. So overall, a high level of success and a return to sports. So we were excited to be able to put this together. We're hopefully drafting a manuscript to share it more broadly, and I'm glad to be able to share it here. So thanks for the invitation.
It's very important work. I enjoyed it at the ICRS and again today. I think that it comes up a lot with athletes, at the NFL Combine, in your office, and the colleges, what's my probability of returning to play? Or what's the probability of that athlete returning to play in certain cases? And we're asked to weigh in on. I think telling them 85% might be the best estimate I have based on everything I've seen. Would you agree?
Yeah, entirely. If there's a complex knee, it was mentioned with ligaments, realignment, cartilage, I think 80 to 85% is an exceptional result. And again, if we can get that 10, 15, 25-year durability before conversion to arthroplasty, I think patients are satisfied. I think with those statistics too, they can stomach the timeline to recovery. That I preface again pre-op conversation that this is a long haul, and we're going to be in this together. And it does take 9 to 12 months for the cartilage to mature and for you to resume your strength and stuff. But if we both see the end zone together, that 85% of patients are going to get back to a high level of activities, and they say, well, I'm being recruited for this or that. I have a competition. I have a passion to ski with my kids. I can say, give me 9 to 12 months, and the 85% chance we'll get you back where you want to be.
Mm-hmm. I like that. Well, we'll transition now into Dr. Kreitler.
Dr. Carey, so I've got 2 cases for you all this evening. The first one's fairly straightforward. The second one's a little interesting and unique. So this first patient's a 29-year-old male. He's an Air Force pilot, and he sustained a right knee injury, first-time patella dislocation after falling during obstacle course training. And so when he first presented to me, he had an MRI that demonstrated a concern for a full-thickness chondral defect on his medial patella, as well as an expected MPFL injury. And so after assessing this patient and seeing this imaging, I explained, just as I previously mentioned, that I would recommend a 2-staged surgical plan. And during the first stage, diagnostic knee arthroscopy, I found a full-thickness chondral lesion on his medial patella, which measured about 1 by 2 centimeters, as well as a loose chondral body in his lateral gutter, which I removed. And so this sort of confirmed my original plan. And so I discussed with the patient that I believed we should agree with the second stage of his procedure. And so the second stage would include MACI implantation to his patella, as well as an anteriorizing TTO. I always do a TTO with any patellofemoral MACI procedure. There are multiple studies showing higher success rates when you perform a TTO to offload that patellofemoral cartilage procedure. And so I do it every time. And then, of course, MPFL reconstruction, I use a semitendinosus allograft. So just some pictures from his second stage of his procedure. On the left is the MACI implant on his patella, and then a tibiotubercle osteotomy to anteriorize the tibiotubercle and offload the patellar cartilage procedure. So the second case is a little unique.
Can we talk about the first one, or?
Sure, we can.
Let's talk about this one. This is a fantastic case. And then how long afterwards did you protect their weight bearing and their motion? And do you remember any?
Yeah. So for these cases, patellofemoral, MACI, and a TTO, I have these patients non-weight bearing for the first 2 weeks, and then toe touch weight bearing for the next 4 weeks. They're in a brace lock straight when they're ambulating or sleeping. When they're just resting, they can take the brace off, start some motion. But whenever I do a MACI, regardless of the location, for the first 48 hours, I keep them locked straight for 2 days, just to let that MACI implant start getting stuck in there, and just to further assure myself that it's not going to move once the patient starts moving. So that's my general plan.
For the tibial tubercle osteotomy, do you completely free it up distally, or do you leave it hinged and kind of crack it?
No, I completely free it up. And my plan on those TTOs is really based on various measurements that I make preoperatively. So how much do I want to medialize based upon the TTTG? How much do I want to distalize, if any, based on the Insel-Salvati ratio? And then with any patellofemoral cartilage procedure, I want to anteriorize. So based upon all those things together, that tells me at what angle I'm going to make my cut, but I always completely free it up and really make sure that I'm moving that tibial tubercle.
And then you mentioned this one was more of like a pure anteriorization.
Yeah.
Can you talk a little bit about how steep you're willing to make the Fulkerson type angle, or do you ever switch to a different sort of osteotomy?
So if I'm just anteriorizing, then I'm cutting. I always go over to the medial side of the patient and I cut down away from myself, and I go at probably a 60-degree angle from the horizontal if I'm just trying to anteriorize.
Okay.
Dr. Carey, I agree. Two pearls I wanted to elaborate. I used to allow more weight bearing, and I had one unfortunate proximal tibial fracture as a result of an early postoperative fall. I'm very conservative in my practice, and I keep them non-weight bearing, even with the osteotomy and the cartilage repair. I know TTOs can probably bear weight. I assume a lot of my patients are, but I like to give them instructions that's limited weight or non-weight bearing for that 6-week duration. And I echo what you say about terminal extension is our number one goal. I think we capture that in the first 48 hours of a locked extension bracing. I think the location of the patellar defect, like you say in your pre-op planning and your TTTG and your Insel-Salvati ratio, helps with your direction and extent of osteotomy. The location, if it's central or distal facets, I think benefit from that anteriorization. And I've found like an anterior slide osteotomy almost works better than an oblique, like a 60-degree angle. I might use a 90-degree saw blade to get that posterior cut in line with the posterior cortex, and a more of a vertical cut and able to do a vertical slide of the tubercle per se. Then secure it with transverse screws more so than A to P screws.
Yep.
The other alternative, sorry, I had some background noise, but a proprietary third-party software surgical system can do anteriorization with a bone block or with bone paste behind. The Kinemed system, for instance, can be cortical sparing, and you can more or less do an in situ osteotomy with their hardware, with their guides, so that you can get medial lateral cuts and you can bring the tubercle forward with synthetic calcium phosphate graft behind, which I found to be kind of interesting, and I use for my distal and central lesions, for instance.
And then can you both comment a tiny bit on distalization? And sometimes the patellar tendon's like 65 and the patella is 40, but how far are you distalizing? And then we can talk a little with Dr. Lupowitz about getting motion back after these distalizations.
So my goal is to make the insult-to-body ratio 1.0. And usually if I'm distalizing, I really only need to distalize 5 to 8 millimeters to accomplish that goal. The furthest I've ever distalized was maybe 1.2 centimeters. And that might take a little bit longer to get their flexion back. But that's my general plan.
I agree. I'm sorry. Go ahead, Dr. Luke.
I was just going to say, in terms of distalization, obviously I'm going to be a little bit slower in terms of range of motion. I still want to keep the joint healthy and keeping active flexion moments just to get that synovial fluid moving around, keep that cartilage surface healthy, but limit the amount of intact or contact pressures that are going to go across that joint. One, it's going to be a little bit painful for them. Two, I want to respect the surgical healing process. And three, I just almost always find that we're going to get it in due time. And we know that we have a long-term approach to this. So we want to keep the patient calm, healthy, take what we can. And I always say, like, kind of push to it, but not through it. Just to allow for an easy process to get that motion back. I'm more concerned with the terminal knee extension being symmetrical side to side versus the long-term time of flexion, because I know that'll come.
Yeah,
sorry. One of the pearls I find to be kind of annoying is that cortical healing, right? The anterior cortex, when you do a complete mobilization of the tubercle and you're trying to get it to heal, or if you're doing distalization and you resect, again, I'm aiming for about a centimeter or 1.0 in terms of correction or goal correction. But that abutment of cortical bone at the anterior cortex and your lateral view x-ray can be kind of stubborn to heal. Two pearls I like to use are one cancellous bone graft. So maybe even a curette or rongeur in that proximal tibial bone is perfect. You only need a small amount and you can kind of pressurize it into the cortical defect where you're reapproximating. And two, I like your x-rays here, Dr. Kreidler, where 3 screws I find are beneficial if it's mobile or distalized. If you have an intact cortical hinge distally, I think the biomechanics support 2 screw fixation. But if it's any more insecure than that, and you lose your cortical hinge inadvertently, or you intentionally distalize or mobilize the tubercle completely free, I think a 3 screw construct, sometimes even a more transverse in between the 2 A to Ps, is a helpful way to make sure you're secure. Because beyond a proximal tibial fracture, I did a loose fixation in one tubercle with osteotomy also. So I get pretty particular about it now.
That's fantastic. I do want to present a little different approach. When we look before how many times I was doing a tibial tubercle osteotomy for patellofemoral cases, it was about 1 out of every 6. I was kind of reserving it for ones where their TTTG was more than 20, infralateral ones. I was a bit more conservative. I believe now it's probably 1 out of 3 or so, but I just want to make sure that the attendees know that it does not have to be 100% of cases. You can be a bit more selective, especially if it's in a bit of an atypical location. Now, I'd like to hear your second case, Dr. Kreidler.
Yeah, so this is a unique case. This is a 25-year-old female who was referred to me with right knee pain for years. And she reported to me when I first met her that she had received approximately 20 intra-articular corticosteroid injections over the previous 5 years by another orthopedic surgeon in a neighboring town. And so clearly that's just putting a Band-Aid and not addressing the real issue. So I set out to figure out what is really going on here. So I always do a very thorough exam. And based on my exam, it seemed that this patient really had 2 main issues: patellofemoral and lateral compartment. She had a positive patella compression test, as well as tenderness to palpation over her lateral joint line. Now, on MRI, she was found to have a concern for a chondral defect on her medial patella. So that explains the patellofemoral pain. But why does she have this lateral joint line pain? Well, on her long leg alignment films, she was found to be in valgus malalignment. So that explains that. So again, I recommended first doing a knee arthroscopy to assess the situation, really take a closer look at her patella, see how big that chondral defect was. And, I don't have the MRI images here of her lateral compartment, but I didn't see anything on her lateral compartment on MRI. So I really wanted to look more closely during her knee arthroscopy to see what's going on over there. Is there any cartilage damage? Is there meniscal damage? And so we proceeded first with a knee arthroscopy, and this left lower image is her patella. She's found to have a full thickness chondral lesion measuring about 10 by 15 millimeters. And then looking at her lateral compartment, completely clean. Okay. Her cartilage was pristine. Her meniscus looked perfect. But I am very much of the belief that I want to address all issues. And, based on my exam, this patient has 2 issues. And if I just address her patellofemoral pain, there's a very good chance that she's still going to have this lateral compartment pain, and she's not going to be completely satisfied. So I really want to address everything. And even though her lateral compartment looks very nice inside, she still has lateral joint line pain, and we know why. It's because of her malalignment. And so I recommended correcting her malalignment with a lateral opening wedge distal femoral osteotomy, as well as doing what we did in our first case, MACI implantation on the patella and an anteriorizing TTO. And these are her images. She's doing really well. She's only about 2.5 months out, but I think she's going to do really well for this. And I'm happy that I addressed all issues, and I don't have a concern that she's still going to have pain because I didn't address everything.
That's a great case. Now, that exposure of the patella there, is that through like a lateral release kind of lateral exposure, or is it medial?
So good question. Whenever I do patellofemoral MACI, during my knee arthroscopy, I always make sure to put in my operative report, where is this defect? If it's on the medial patella, which it was here, this is through a medial parapatellar arthrotomy. If it's on the lateral patella, I'm doing a lateral parapatellar arthrotomy. And then her DFO is through a separate incision to the IT band laterally.
That's excellent. This is a big case, and kudos to you. How I found similar in these valgus patients, trochlear dysplasia may be present, and we end up with a flattened groove and/or trochlear malrotation. I think that even just a varus producing a distal femoral osteotomy helps to kind of correct that, and may arrange for some of that correction and rotation without you having to plan for it surgically. So this, I think, will address all of our sources, and be curious to see what the results are long term.
Yeah,
I apologize for missing the Q&A questions. One was asked at 6:34. I had a webinar chat up, but not the Q&A. It was my fault. One was for your last case. What was the lateral to medial screw for?
We had an extraarticular fragment break off during the case, so I just fixed that. So that's not standard for me.
That sounds stressful.
It was extraarticular, so it was less stressful than if it was intraarticular.
And then there's another question. What is the reason you all prefer to use Insall-Savati ratio versus Catan de Champs?
It's just what I was trained on. You can use either one, but my opinion on that is, as long as you're staying consistent, I think either one is fine.
I agree. I'm just kind of habituated to the Insall ratio. Catan de Champs is equally effective, and if that's what you prefer or you've been exposed to, you won't be wrong.
Yeah, I don't think it's going to make a major difference in your surgical procedure if you use one over the other. As long as you're staying consistent and adhering to the same principles, you're going to do the right thing.
Okay. And then Did you put any stock in, was there any bony edema in the lateral femoral condyle on the MRI that for being overloaded or nope?
No, totally clean. But she showed me on exam that she was having pain over there, and there was a reason why. And my feeling is, if I don't do anything about it, that lateral compartment is not going to look like this forever. Eventually, it will start to wear down, and so I want to correct that malalignment before it starts breaking down.
Yeah. I like that approach. And she was crooked and you made her straight. And I think that no one can fault that. What if someone was straight? Do you ever entertain making them crooked to unload a troublesome compartment with meniscal deficiency and cartilage deficiency?
Yeah, so I would definitely do that. Let's say we had lateral compartment pathology and the patient was either completely neutral alignment or, 1 degree or 2 degrees in valgus. I will put them in a little bit of varus to offload that lateral compartment. So yeah, I will.
How about Dr. Meininger?
I agree. I may have a neutral right in a varus or a medial compartment disease, a neutral long leg alignment film through the medial tibia eminence, but I might make a 5-degree wedge correction, usually based in the tibia. I think it can just mechanically unload, even if we are already neutral. Osteotomy plus mechanical realignment helping to increase success rates for cartilage repair of all types. So for my MACI patients, my osteotomy rates are almost 100%.
Dr. Lupowitz, can you comment at all on return to soccer and some of the sports? If they have one leg corrected but not the other, and then have you noticed any issues with that?
Yeah, I mean, I can't offhand say that I've noticed anything direct, but I would be remiss to say that most individuals don't neutrally or naturally just have some sort of either structural or functional alignment issues when they move and perform sport. And a lot of these sports are, whether it be bilateral, they're one side dominant, where they're going to be performing things more in a unilateral capacity. So I think just working with whatever it is that they have from a structural sense to match the functional demand of the sport, and then just have an understanding of what biomechanical factors are going through that limb with the movement specificity at hand, just to ensure the long-term health of the individual during that play.
Mm-hmm. And then Dr. Lupowitz, what kind of things do you look for at the end? Like, and then we'll talk with the surgeons too, but like at the end, like they're ready to graduate from your care. What kind of features are most important to you?
Yeah, I think first and foremost is confidence and the ability to do things under chaotic demand. It's one thing to just do a squat or just do a single leg hop, which is, most often just based on the constraints of like the clinical setting that we're evaluating them in, maybe what we're looking at, but actually getting them to do things with multiple tasks at hand, because sport is not going to be straightforward. They're going to have to make decisions while doing certain tasks and really challenging the neurocognitive aspect. Aside from just the structural and biomechanical factors, we've been working on that for up to 6 to 9 months. And then those last 3 months when we can really start to truly load that cartilage and test it now that it's filled in all the way and has the structural integrity to accept load, I think we should have at this point in time be functionally sound. Squat patterns, lunge patterns, hinge patterns, those should all be refined by that point, so we can really start to challenge them from a neurocognitive sense as well, to ensure that they can handle the demands of sport.
Dr. Kreitler, what kind of things do you look for in the office, and do you do any surveillance imaging at any time points?
I did on my first few cases at 6 months, just to make sure that everything looked good, and sort of for my own personal education, as well as educating my residents on what this can look like at 6 months or later. But beyond that, I don't do any routine surveillance. And in terms of return to activities, the therapists I work with, they have all the rehab protocols, and I really leave it up to them. I'll always ask patients, whenever they come in. What are you doing these days in therapy? What's the latest advancement that you've gone through with your therapy? But unless something is not going well, I sort of leave it up to the therapist on their advancement.
Sidebar, thank you for that. I appreciate that.
You're welcome.
Dr. Meininger?
I agree. Routine surveillance imaging or repeat MRIs are not a general part of my cartilage repair. I think it can kind of cloud the confidence too if you get them too early. I wouldn't do it before 6 months either, Dr. Kreitler. I think that some of that reactive marrow edema, the lack of graft maturity, some of these signals, and if your radiology team isn't familiar or routinely reviewing cartilage repair, again, we're community-based. We don't even have 3T. We've got advanced 1.5T MRIs, but we don't use advanced cartilage imaging techniques, for instance. So getting reports back that read progressive chondromalacia, reactive edema in these early settings can cloud the confidence in the patients. Two, I base it on their function. Unless we're abutting an issue that range of motion is not on track, recurrent effusions present, then we may have to pursue workup. But otherwise, once the osteotomy heals, no additional x-rays and MRI, hopefully not at all, because their clinical success and their progression through PT is on track.
I would like to address two more Q&As from the audience attendees. For Dr. Kreitler's second case, do you adjust your TTO angle or degree of medialization when doing a distal femoral osteotomy, given that a varus-producing DFO will reduce the TTTG?
In this case, I didn't really medialize more than I would just to anteriorize the TTO. So that has not actually come into play for me yet. I would have to think about that. Any thoughts, Dr. Meininger?
Sorry, repeat it again for Dr. Carey. What was your question?
It was complicated. Do you adjust your TTO angle degree of medialization when doing a DFO, given that a varus-producing DFO will reduce the TTTG?
Right. I may find also that I have to pop the hood, if you will, and do that TTO to expose the patella. In that case, the TTO may be less than a centimeter or so. My medialization depends on the location again of the defect. If it's pure central, I want to get a 60-degree type osteotomy. If it's more lateral, I'll go for 45 to get more medialization. So the combination doesn't necessarily direct me. It's more or less the location of the defect that's going to help me with my osteotomy planning and exposure.
Thank you. And then the second question kind of ties in a little bit to what I was asking earlier, especially with soccer athletes and their acquired varus, and sometimes they miss it. I've heard an Italian cartilage surgeon say before not to tinker with their alignment or they'll hate you. I don't know if that's true, but in cases with bilateral coronal malalignment but unilateral cartilage defects, how often do you follow up the MACI and osteotomy with a contralateral osteotomy for symmetry? Was one of the questions from the attendee. Good question.
I have a interesting case. Sorry to interrupt, Dr. Kreitler. 14-year-old with extensive 12-degree valgus deformity and patellofemoral instability. I had to take a similar approach with an opening wedge DFO to correct his valgus and hopefully address some of his rotation because he was dysplastic with an increased insole ratio and had a loose body due to a patellar chondral defect. So staged approach, but now his injured knee is neutral and the contralateral side remains in 5-8 degrees of valgus, but I'm hoping just to leave him alone, and that would be my approach. I don't think there's any preventative measure in re-correcting him. I think if he should develop a patellar instability with his unaddressed deformity in the uninvolved knee, perhaps we'd come to that, but I'd let clinical presentation direct me on the uninvolved side.
Yeah, I really don't do surgery on asymptomatic joints, so not until symptoms start happening.
Well, excellent. And now I can take over again here. Go. Some good introp images there. And we can talk a little bit about the rehabilitation after MACI, and if Dr. Lubowitz has any good pearls for us.
There we go, just unmuted. Yeah, I think we alluded to this earlier. I think the biggest overarching aspect of the rehabilitation is the team-based approach and the communication component. I think it seems like you guys all in your respective areas have therapists that you lean on and trust and communicate with, because each case is so unique. And it's, even though we have these protocols that are semi-standardized, it's important to obviously follow the guidelines set forth, because a lot of smart individuals came together and figured out what works, but always having that individualized approach for each patient is going to be most keen. And I just don't have access to advance the slides here. Perfect. Yeah. So like we said, adherence, specific factors, communication, having that goal focused, especially later on. Timelines are one thing, and biological healing is one thing, but the way that the individual presents will be another. It's one thing to just assume that at 6 to 9 months, an individual is going to be ready to run, but it's another thing to, from a therapist side, watch them run and be like, hey, maybe they didn't necessarily know how to do this in the first place, and it may take a little bit longer to teach them. And then having a respect and understanding for your load bearing based on where that defect may be, and then sort of knowing when things are going south. From a therapist perspective, understanding that if things are going smooth, but all of a sudden we're starting to notice some increased swelling, catching, mechanical symptoms and reports, then it's important to get in touch with the surgeon pretty immediately for follow-up, because you don't want any overgrowth. And what's nice is that we do have these resources where the protocols are publicized, and then an additional MACI mentor program, just to allow the individual to have a means of communication with someone else who may have gone through a similar procedure to them. This is a long-term approach, and it's one thing to have access to your therapist, your physician, and your family, but to actually resonate with someone who's gone through it, because, from our perspective, we tell them it's going to be okay. And yes, there's this 85% possibility for return, but it's hard to see firsthand when you're speaking with individuals who haven't gone through it themselves. So getting them in touch with someone who has can be pretty game-changing for them. And I believe this is just a way to get in touch with certain individuals. And then in addition, I think you guys can speak a little bit more so to the insurance aspect of things from an approval perspective, be it that there was via insurance, roughly 90% were approved. So that's usually a common question asked is this covered by insurance? Again, just another touch point on this MACI Mentors program, where it can be valuable to speak with someone one-on-one. And then even from a therapist perspective, I believe that there's a hotline to get in touch with MACI credentialed therapists who, see a high volume caseload, kind of like myself and others through MACI, just to get an understanding on specific case-by-case basis to have that point of line.
I think that's really important to understand that there are resources out there. There are people to talk to, physical therapists and surgeons to talk to for challenging cases. And I definitely enjoy that kind of work. We're at 59 minutes. And I see there's no questions in the Q&A. I do want to remind people that there's one more of these work of art MACI courses. This one's a work of articular cartilage repair, where Dr. Ons and Dr. Minus, Dr. Romanelli are going to give some of their overall pearls for things to consider for articular cartilage repair. There's a QR code that you can scan there to register. We'll leave this up for a few more minutes. Thank you for coming. I really appreciate people attending, and the presentations from Dr. Kreitler, Dr. Meininger, and Dr. Lupowitz. I've really learned a lot, and I hope you learned some as well.
Indication: MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the knee, with or without bone involvement in adults. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, products of porcine or bovine origin, in patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders, in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant, or in patients unable to cooperate with a physician-prescribed post-surgical rehabilitation program. Malignancy. The risk of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of malignant or dysplastic cells present in biopsy tissue during manufacture and subsequent implantation may be possible. Transmissible infectious diseases. Because patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases, cartilage biopsy and MACI implant may carry risk of transmitting infectious diseases. Presurgical comorbidities. Local inflammation or active infection in the bone, joint, and surrounding soft tissue, meniscal pathology, cruciate ligament instability and misalignment should be assessed and treated prior to or concurrent with MACI implantation. Product sterility. Final sterility test results are not available at the time of shipping. The most frequently occurring adverse reactions reported for MACI, greater than or equal to 5%, were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. Use of MACI in pediatric patients younger than 18 years of age or in patients over 65 years of age has not been established. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to an infant has not been determined. To report negative side effects, contact Vericel Corporation at 1-800-453-6948 or FDA at 1-800-FDA-1088, 1-800-332-1088, or www.fda.gov/medwatch. For more information or to view full prescribing information, please go to MACI.com.